people, they get confused about where the real risk lies. But with surgery, of course, there's risk and then there's therapeutic potential. So with cosmetic surgery, there's a happy place where if you take the right patient, right, who's the right candidate, both anatomically and like psychologically, you have the right candidate, you perform the right surgery that's appropriate for that person. They can look much better, they can feel much better, and that's like a beautiful thing. Um, but if you choose the wrong person, if you choose the wrong surgery, if you perform the surgery incorrectly or whatever, you know, things could end up even worse, than where they started.
Plastic surgery is controversial. Critics claim that it promotes unrealistic beauty standards and that aggressive marketing targets impressionable people who are already under enormous pressure from social media to adjust who they are to meet some socialized view of what beauty is. At the same time, our society values personal autonomy and individual choice, and plastic surgery can have a positive impact on mental health, self-esteem, and quality of life. That's what the conversation today is about. I speak with double board certified facial plastic surgeon Gary Linkov about the ethics, impact, and practice of plastic surgery. The one thing that shines through the conversation is the care and compassion that Gary has for the health, well-being, and happiness of his patients. If you're not familiar with his work, I highly recommend checking out his YouTube channel, linked below. I'm Shane Farnsworth, and this is the Escape Sapiens podcast, supported by the Andrea von Braun Foundation. If you enjoy these conversations and want to help support me, the best way you can do so is by liking, sharing, and of course, subscribing. And now, I'm pleased to bring you Gary Linkov. I hope you enjoy.
Escape Sapiens.
I know that you started off with an interest in psychology and you also have training in painting and sculpture. What made you decide to go into plastic surgery and why specialize in hair restoration and facial procedures?
Yeah. So in medical school, I always thought that I was going to be an ophthalmologist, an eye surgeon. I liked learning about, the senses, and I liked the kind of like more like microscopic type of work. But then in med school, I had a required week on ophtho, and then the following week was ear, nose, and throat, or head and neck surgery. It's also called otolaryngology. It's like has multiple names, but it's basically everything above the clavicles that's not the eyes or the brain. It's like everything else. So I was never on my radar. I remember as a kid, they wanted to remove my tonsils, and my mom always fought the doctors on that. So I never had my tonsils removed. But that's like as much like ENT that I ever really thought about. But then I loved that week on ENT. I don't know, it just felt like I was more at home. I liked the blend of microscopic procedures, but then we also would do like big open like neck surgeries, cancer reconstructions. There was a lot more. There was plastic surgery with the eyes, but with, the head and neck, there was a little bit more involved. So I was just like, yeah, I think this is actually more of what I want to do. I've always been interested in art, taken classes, courses, did some stuff on the side of my own, just since I was a kid. And yeah, and then so I love the head and neck anatomy. I liked again like the different types of surgeries that it offered, but really it was still very much related to the senses and the anatomy. The anatomy was very interesting and difficult to understand. It wasn't like something that you just read in the textbook, and the only way for you to truly understand it is to like see it in real life and see different tissue planes open, and that to me was fascinating, So that's what drew me to like the specialty of like head and neck surgery, ENT. And then during residency, I like the plastic side of things. I mean, there was like deep ear surgery that we did. That we did a lot of sinus surgery. Again, those big cancers, like all that was interesting, pediatrics. But I like the reconstructive plastic surgery, the trauma plastic surgery, the cosmetic stuff was interesting because of like the artistic things you can apply. Because you have like this big gaping hole. It's like, how do you close it? There's not one way, right? So you can get creative that way. So then after residency in head and neck surgery, I went on to do a fellowship in facial plastics and reconstruction. And so it wasn't all cosmetic. It was like a portion was cosmetic, but a lot of it was trauma surgery. A lot of it was cancer reconstruction. So That was great. But then during that year, I did just like a side like elective. It was just a like a long weekend on hair restoration, and I had a full head of hair at that time. I mean, I didn't really know a lot about hair restoration. We had some required like questions on our tests in residency, so I had to learn it to a degree. But I'd never seen a hair transplant. I never really looked into. I never thought like, oh, I'm going to be doing hair surgery. But I did this weekend course in Miami with a guy who had my background in head and neck surgery. But then in his fellowship, he did a lot of hair, which I did not do in my fellowship. So he ended up doing like a combination of facial plastics, but a lot of hair surgery. And then ultimately offered this course, which was free for fellows. And I was like, oh, it's cool. Spent some time in Miami. When I was there, I was kind of drawn to it. I thought it was like super cool. Didn't really consider it before. And then his team proposed this idea that they knew that when I was done with fellowship, I planned to come back to New York and start a practice. And they're like, oh, do you want to work with us part time? And essentially be our like New York City arm for their hair practice. And at that time, that surgeon was coming to New York, doing some hair cases, every month or so. So I would like drop. So ultimately, we ended up doing this deal or this apprenticeship in a way where I had my own practice that I was just like starting from scratch. So it was very slow. I had a part-time job, actually two part-time jobs. One was virtual, one was at the VA in person. And then I worked for this guy, doing hair surgery that he would essentially send me patients and send me technicians. And I was like learning, the art of it, the technical stuff. I was doing every part of the surgery with the technicians. I would spend time in his guest house in Miami, go to work with him like every once in a while to brush up on the skills, all that. And that's kind of how I got into hair. And then around the time that I was starting with him, I had like one big patch open up on my head,
Mm.
bald spot, alopecia areata, and I had like on my legs, I had little spots like going back 10 years, but never on my head. So that was interesting. So I remember he used to like inject it with steroids, eventually, whatever, it grew back. And then around COVID time, which was literally like just a couple of months before COVID, uh, this hair surgeon and I decided to kind of go our separate ways, and I took all the hair activity under my belt, uh, and I started to like rapidly shed hair. So I don't know if you had a chance to see. I have a video on alopecia areata, but like my journey, you should check that out because it's literally like my experience with hair loss, which was rapid loss. It's not like
Mm.
most of the hair loss that I actually treat. So I developed alopecia areata universalis. So I lost all the hair on my body. I had no eyebrows, no eyelashes, nothing, no hair at all. And that was interesting. So we'll get more maybe into that later. But so that I think it wasn't the reason why I got into hair was like I had like
Mm.
no hair. I had like a really, really strong hair up until I guess 34 or so. So that wasn't the reason I got into it, but it surely, I think, became the reason why I decided to like really focus in and almost
Mm.
exclusively, like dedicate myself, my practice to hair because I have a lot of other skills that I don't use much of anymore, which is a little sad in a way. But I'm able to really do like world class like hair surgery,
Mm.
and build out a team around that. So that's kind of how I got into hair even more.
So you could really understand the psychological aspect of losing hair. This
Yeah.
is actually a nice segue into the next question, which is, plastic surgery is in some sense controversial, right? There are these stereotypes associated with it, maybe vanity, breast jobs, celebrity, botched surgeries. You hear all these different things in the news. How do you address those stereotypes and criticisms while highlighting the valuable and meaningful aspects of the work that you do?
Yeah, that's a great question. Basically, surgery, any kind of surgery, it's like a medication. Sometimes people think surgery, medications, they think it's totally different things. But I mean, it's you're trying to give people something to like improve their life or help them live longer or cure a cancer or help them feel better about themselves. It's all more or less interrelated. And when you have a medication, uh, people talk about supplements and like whatever, but if it and some supplements obviously work and can help, but when you have like an actual like drug medication, it has its like therapeutic window. So if you underdose somebody, then like nothing really happens. Like you're not really treating the condition that you're trying to treat. If you overdose somebody, if it's a strong enough medication, it can kill them, and that's just how it is, or you can get really bad complications or side effects, right? So it's trying to find like what's the like ideal like therapeutic window. And so surgery is pretty much the same. You can go in there and let's say you're doing a cancer surgery, right? Because sometimes cosmetic surgery people think, oh, that is so different. But it's the same concept. You're doing cancer surgery, you go in there and you don't get the whole thing out, right? That could be for different reasons. It could be for lack of skill. It could be just because you went in there and the cancer is spread and it's impossible to get it all out. But either way, whatever the reason is, you've essentially underdone the surgery, and that may have been in your control and may not have been in your control. And then the cancer spreads and it can kill the person, whatever, right? They might need chemo, whatever it is. Um, or you can go in there, right, and you get the cancer out, but you've also now destroyed some other normal tissue, right? And sometimes that's inevitable, but sometimes it's actually preventable. But let's say someone is a little bit more, I don't know, maverick, and they go in there and they take out, like, let's say it's a throat cancer, and they take out more than what was needed. So now the person might be cancer free, but maybe they don't have a voice box and they have to talk through a hole in their neck. And maybe that was totally unavoidable, and that just would have been the case anyway. Again, it's just as an example. But there are times when you can preserve an organ, for example, and still get rid of the cancer, right? So again, therapeutic windows. Sometimes the only way to help someone is to do something a little bit more involved, right? To
Mm-hmm.
address the issue. So kind of translating that to cosmetic surgery, it's similar, right? So like some people think, oh, all I need is a little bit of Botox or all I need is a little bit of filler, right? These things are not without their risks. So even though it seems like a more minor thing, it doesn't always address the problem, right? Like someone's trying to look better, they're trying to look more lifted. They might get filler and it might actually make them look more heavy. They think that they got away with like a cheaper, safer alternative. Meanwhile, filler has real risks. So when I go and I operate, especially the surgeries that I'm doing these days, um, I'm not really like worried that I'm going to do something so catastrophic. Especially most of my surgeries nowadays are under local anesthesia. People are awake. So, the biggest risks with surgery usually are anesthetic complications.
Mm-hmm.
Like they get put under, they could have a real problem. I mean, there are rare things that can happen. When patients are awake, it's much harder to really like screw something up, at least as far as like purely like safety, and from a safety
Mm-hmm.
perspective. I mean, of course, aesthetic, that's a different thing. But so when I go into surgery, I'm not worried too much anymore about like that kind of stuff. When I was doing filler injections, in the back of my mind, knowing as much as I know about what could happen, if you don't know, then great. You're kind of in your naive approach. You're just injecting people. It's fine. But when you realize that, like, you could get filler into a blood vessel and it could cause someone blindness, it can cause a stroke if it's like bad enough. I mean, those are types of risks that just don't exist with especially the types of surgeries that I'm doing. I mean, there are surgeries where
Mm-hmm.
those risks are real, but so in many ways, non-surgical things sometimes can be more risky than surgical. And so people, they get confused about where the real risk lies. But with surgery, of course, there's risk and then there's therapeutic potential. So with cosmetic surgery, there's a happy place where if you take the right patient, right, who's the right candidate, both
Mm-hmm.
anatomically and like psychologically, you have the right candidate, you perform the right surgery that's appropriate for that person, they can look much better, they can feel much better, and that's like a beautiful thing. Um, but if you choose the wrong person, if you choose the wrong surgery, if you perform the surgery incorrectly or whatever, you know, things could end up even worse, than where they started. So the way I see it is a lot of times things aren't really being selected properly. Surgeries aren't necessarily always being done appropriately. They're either being overdone, underdone, right? Where you like, let's say you're trying to do a facelift for someone, and you decide, you know what? I don't really know the latest techniques because maybe you're an older surgeon or you're just, I don't know, you just like didn't really learn too much about facelifting. And you're like, I'm just going to go trim a little bit, make the same cuts as you would for any facelift. But now I'm going to just pull the skin really tight, cut a little bit of extra skin, suture it back up. Easy fix, easy peasy. You do it at local anesthesia in the office. Uh, Patient, they look tighter. They feel maybe good for a couple of months, but then you realize that the scars have like widened because there's too
Mm.
much tension. The skin has gone back down to where it used to be after a couple of months. Uh, the person they're pissed off. They're not happy. They're not happy. They have these scars. They don't look that lifted. They don't look too rejuvenated. That may have been a cheaper surgery, may have been a surgery that was
Mm-hmm.
sort of easier to do. That doesn't mean it's achieved the outcome that was actually like sought after. So I mean, I think a lot of this stuff comes down to nuances and not just saying like, oh, cosmetic surgery is good, cosmetic surgery is bad. It's like it can be good and it can be bad. It's just like I think people haven't stopped to really think about the nitty-gritty, like detailed, nuanced approach to, and this is like, imagine, I don't even, it's not like I was ever trained to do all plastic surgeries that are cosmetic, right? There's so many different kinds. So I usually will stay within my lane of the stuff I know really well, to give people all this information so that they can make informed decisions, you know? But there's lots of other, body plastics that's not even my background. But each thing has like it's like nuances of surgery and when you should do something, shouldn't do something, lots of different things. So, and that goes to another thing, which is like people should select surgeons based on the actual surgeries that they're doing most often and not just like,
Mm-hmm.
oh, I found a great plastic surgeon, he can do my facelift and my breast implants. Like he's probably not going to do an A+ result on both. You know,
Mm-hmm.
if he's great at breast surgery, great, go to him or her for that. But maybe pick someone else who's doing facelift surgery on a at least weekly basis, if not even several times a week. But that's, I guess, a different topic.
So then you mentioned good candidates. So for you, who is it that makes a good candidate, and to what extent do you have to play the role of, say, a psychologist when you are speaking with people who are potential patients of yours?
Always always I want to take off the psychologist hat as early in the conversation as possible, um, but I keep it on until that moment when I realize that the person who's I'm talking to uh, understands, the pros and cons of surgery, is hearing me on, they come to me and they say, oh, hey, I want this. So yeah, but like sometimes people just don't listen. They don't listen, and that's not great for me, right? Because if I feel like they're running a script in their head of like what they want, and I tell them that based on what I'm seeing, this is what I would offer you, or this is the way
Mm-hmm.
I think you should like consider, your options, whatever. Some people, most people react, well to that, and they're like, okay, yeah, I hear what you're saying. Like that makes sense. Maybe they didn't think about it that way, or or based on what I told them, then they respond. But I have some folks who they just have there's something running in their head on loop, and I can't break through to that. And that's
Mm-hmm.
not a good candidate because listen, surgery, it's fraught with lots of things that could go wrong. Not major things necessarily, but minor things sometimes. And I need to be able to work with them. Like, let's say they have an
Mm-hmm.
actual post-operative infection. Like, will they trust me? Will they listen to me? Will they? So if I can't connect with them, um, initially in the consultation, then I just really don't take them on as patients. So that's one scenario. And then, yeah, I mean, there's anatomical considerations too. Someone who wants their lip lifted, but they have very little room here to do lifting, on, is not a great candidate. Even if in their minds, maybe they think that they'll look better that way. But I know that, I kind of have to project out, like, let's say we do the surgery, then what? Are they really going to be, am I going to, the question I ask myself these days more than anything else is like, can I make them happier?
Mm-hmm.
So if they come off as super depressed, and super negative, and they're kind of clashing with me on certain things, um, then the answer is going to be no in my head, right? Like, but if they have the right anatomy and their ask is reasonable, and they hear out what I have to say and they want to work with me, then usually the answer is yes, to that. So that's the way I see it in an elective, purely elective cosmetic space. That's the way I frame it these days in my head. Can I make this person happier? Uh, and yeah, that's just the way it is because it's different. It's not like, we're not doing cancer surgery where it's like,
Hmm.
it wouldn't make sense for me to like I just ethically couldn't say no to I could say no to whomever because no one needs this stuff. And I don't work with insurance companies. I don't work at a big hospital. Like no one can tell me you have to operate on this person. It's just like not it's not the world that I'm in. So they're picking me, and they're interviewing me during a consultation, but it's very much working the other way, back at them, even if they don't realize that.
So then, what are the therapeutic outcomes for patients who receive safe and professional interventions? By which I mean, what does the research say? What are the outcomes in terms of depression, anxiety, these sorts of metrics? Is this well known? And I guess the lead on question to that is, do you see it in your own patients?
I don't know about depression and anxiety improving. I'm not sure anyone's studied that in particular. Johns Hopkins has some interesting literature from Ishii, is her name. She's a surgeon, and they've done some nice studies on looking at people before and after, hair transplant, rhinoplasty, facelifting, and how they're perceived by others. Showing pictures to like hundreds of people and seeing like whatever, like randomizing it and seeing how people respond to a before picture and an after picture, but shown, not like a before and after, but like, randomizing it in different ways where you can start to put the numbers together and see, okay, well, it seems like most people are more responsive to someone after they've had a procedure, as far as metrics like successfulness, attractiveness, like that, those types of metrics. So more on the side of perception by others. Uh, but when you look at, I mean, there are definitely studies looking at satisfaction from
Mm-hmm.
cosmetic surgery. I don't know if they've really looked at like, I mean, depression is, I think it goes deeper than just like a cosmetic, like a look or whatever. People have this, and usually it affects many parts of their life, not necessarily just like the way they look. Um, so yeah, I think that would be harder to study, but overall, I mean, satisfaction rates are very high after like these common
Mm-hmm.
types of surgeries. It's maybe less obvious in certain things that are maybe less common types of procedures that haven't been studied as well. But yeah, I mean, most people who go to surgeons who perform like high quality, surgery, end up happy. I mean, most of my patients are happy patients, and some of the surgeries I stopped doing were ones where the overall satisfaction, in my opinion, is generally a little lower,
Mm-hmm.
even in good hands, because they're bigger surgeries. So there are more things. I mean, a hair transplant is big in that it takes a long time, but um, there's just a little bit more that can go wrong with like a rhinoplasty or a facelift. And then, people sometimes might feel that, oh, it's good, but I wish I, could tweak it a
Mm.
little bit there, a little bit here. I mean, in hair, it's somewhat similar in that, like, even if I get a great result that looks very natural, some people will say, oh, I wish it was like a little bit more dense, like maybe we can add some more density, and you can come back and do that. But somehow, most of the time, it's seen like less of a failure than like if someone has a rhinoplasty and there's like a little bump that maybe the surgeon couldn't even prevent, like it's just like a bump
Mm.
that formed as the area healed up. But people can get pissed, they're like, oh well, I went in for a rhinoplasty and you left me with this little bump, and it's like, okay, well, we can adjust that and make that even better. Um, but yeah, but over to go back to your question, overall satisfaction is quite high, again, in practices that are doing things properly with the latest techniques and all of that. Yeah.
One thing that I'm pretty interested in is there's a stigma associated with certain interventions. So for instance, breast implants or having a hairpiece, something like this, whereas other interventions like Botox, for example, are sort of accepted and people talk about them openly. Why do you think it is that certain procedures carry this sort of a stigma and others don't? And particularly things like a hairpiece, which doesn't really hurt anyone, right? And
Yeah.
it's very minimal.
You mean like not a hair transplant, but just wearing like a
Exactly.
system or
Yeah.
a wig or whatever.
Exactly.
Yeah. I think for a long time, male plastic surgery, has been treated very differently from like female plastic surgery. So that's getting to the root of it a little bit, right? Because women wear wigs all the time, and like I don't think anyone cares, right? It's just like normal. So it's taken longer for male plastic surgery to become like accepted and talked about, and it's still just only getting there. So I think there's a gender, difference there. If you ask me more about like Botox versus like breast surgery, then I'd say the difference there is probably more just like the invasiveness of it.
Mm-hmm.
It's just like much easier and overall safer and cheaper to just get like some Botox than to undergo like a more permanent change. I mean, yeah, you can get your breast implants reversed, but you're still going through like, more legitimate surgery. And other surgeries are less reversible, right? I mean,
Mm-hmm.
it's one thing to get an implant and then they just take the implant out. But if it's not implant surgery and you're actually like cutting and lifting and moving and things you can't easily reverse. If you do a hair transplant, it's very difficult to reverse a hair you can make adjustments, but to actually take the hairs out is doable sometimes, but it has a lot of issues. So they're bigger decisions. And I think there's also more potential for people to look more weird for like longer periods of time. So Botox, you can drop someone's eyebrow, you can drop their eyelid, and they might look a bit silly for a few months, but then it's temporary. It comes back, then they look normal. If someone got like a terrible breast augmentation, then it just looks lopsided. It's harder to reverse. They're with it, they have it for longer. If someone had a terrible hair transplant, it just looks fake. And again, much, much harder to reverse. So I think there's stigma on those things probably for good reason, which is like,
Mm-hmm.
hey, they should be handled with more caution.
So have you seen an impact from social media and TikTok now with AI and filters and this sort of thing? Have you seen any new trends that are developing? People seeking augmentations more readily? What are the trends that you're sort of seeing in your
Yeah,
practice?
there's definitely with Gen Z, they're talking about it more. They're more open about getting these procedures done. Like they'll get a procedure and then they'll like put it up on, TikTok. So that sometimes will drive people to do more procedures, right? Because then they're like, oh, well, my favorite influencer had it done, so I might get that too. And that, as much as I like to discuss openness on the channel, we've definitely raised this concern more recently, which is that it's good to be open and honest, I think, about stuff, especially if you're an influencer, to let people know that, hey, this maybe is attainable. I'm not just like born genetically perfect. I had, work done. And so that, I think is overall a good thing. But I think as more and more people go out there and actually share their experiences, you definitely run the risk of the pendulum swinging in the opposite direction, where it's now just everyone feels the pressure to get work done, right? So that's not great. So yeah, I mean, but that's been a trend for sure. Just people being more open and willing to share their journey with their procedures. Uh, Other trends, I mean, there are surely like always like procedural trends. Like for a while, buccal fat removal in recent times was becoming very popular with a lot of celebrities getting it done, where basically cheek fat from the inside of the mouth is removed, and it helped people look like skinnier in the mid phase. But it has a lot of issues, and we have lots of videos that basically just caution people and really point them a little bit away from that surgery. It's not my favorite. But again, there are some people who might be good candidates, but it's usually not like a young person. It's like maybe an older person where there's been like some herniation or pseudo herniation of that fat, that if you're already doing a facelift, sometimes from the inside, you can approach that buccal fat, remove it. But that's like a very specific case, use case. It's not like most people, right? So, but you have a lot more celebrities getting that done, and then they might look okay now, even though some of them already look overdone. But like, how is that? How are they going to age? They're young, they're like 20s, 30s. How is it going to look in 30 years? People don't often think about that. Or facelifts are starting to be offered to younger and younger people, and they're getting it done sometimes in their 20s. A facelift. Back in the day, like maybe 10 years ago, like no one did that so young.
Would you ever do that if a patient came in asking for that sort of a procedure?
No, and to be honest with you, that's another reason. I had many reasons for walking away from certain types of surgeries, but that was one of the reasons why I was more okay with walking away from facelift surgery, because I had many young people coming to me, like people who might want a lip lift, but then like they're like, oh, and they also want a facelift. And I'm like, dude, this is a bigger surgery. This is a lot more potential risks, and we're gonna cause some scar tissue on the inside that, if you get there's a couple of issues. One is the risk that a young person then takes on, when they're like maybe at their prime for whatever they're doing. It's a setback to recover from a big surgery. Uh, Two is like, if they start so young with a surgery that's an aging face surgery, like classic, like aging face, meaning that the face will continue to sag as we age, they're going to be getting more and more of these surgeries done. With each surgery, there's in a way more and more risk, because when you're doing surgery on a revision case, there's a lot more scar tissue in the way. So your risk for hurting nerves is higher. Your risk for hurting the skin, the surface of the is higher, and you're putting people through that risk over and over and over again because they're starting young. And I've seen patients come in for other things now, for me, and they've gone to a surgeon for a facelift at like 28. By the time they're 30, they want another one, because you can imagine at 28 they didn't really need it. At 30 they still don't need it, but yeah, sure, they're starting to notice that, hey, there's like some minuscule amount of drop, of course, because they're aging. But it's like, are we supposed to be getting facelifts every 2 years? It's just, that's an extreme thing that I think carries too much risk to have it make sense. So yeah, so I don't know, I guess maybe I have like more of these ethical like boundaries than some people, but I just wouldn't do something to someone that I wouldn't recommend to like a family member.
In terms of the skill set, so obviously you've trained up to do these procedures. This is something that I want to understand better, because some time ago I was diving, and one of my diving buddies was an eye surgeon, and I was asking him all about how he trained and became, an eye surgeon. And he explained to me that they started off by practicing on the eyes that came from pigs, right?
Yeah.
There's obviously a lot of pig eyes that go to waste. So, yeah. But here you're working on a human's face, right? There's not really the same opportunity, as far as I understand. So how do you get to the stage where you're confident to actually do these procedures on someone who wants to look better, who you don't want them to look worse, right? And it's easy to put someone into the uncanny valley if you do the procedure wrong, I imagine. So this is a difficult thing to achieve.
Yes, for sure. So you start off just with like just basic tenets of surgery. You learn some of that in medical school. You're assisting, not so much on cosmetic procedures. In residency, for at least my path, we worked with some private practice cosmetic surgeons. And, over time, they would let us do a little bit. So you kind of get into it. But, throughout training, you're working with tissue, like live human tissue. Is just you might be doing a slightly different procedure, like it might not be purely cosmetic, but you're reconstructing something on the face. It's the same general steps. It's just that they sort of, maybe the patient needs it more, because you're trying to make them look more normal, after they've had maybe like a cancer or a trauma. But the skills that you're developing are still the same skills. And then in fellowship, you get to do a little bit more of the cosmetic stuff on real patients, that your mentors, your supervisors let you do. So there's like a stepwise kind of increase. But for sure, at some point, all that training ends. I mean, you're still learning, but yeah, I mean, the formal training ends. You don't have like someone looking over your shoulder necessarily. Some people after training, they'll join a senior surgeon. They'll be the junior surgeon because, and in a way, for hair, that's exactly what I did, right? So I had like it was like an apprenticeship. I mean, I only did more and more things as like the senior guy started to feel comfortable with that. But it still was like my malpractice insurance, like it was still my patients, right? If they wanted to sue me, they could just sue me directly. So you start to realize like, hey, this is like on me now. And you're still learning. I mean, you're still improving your skills, improving the actual procedures, because the more obscure the procedure, the more there is for humans to learn about it and to get better at it collectively. So then if you end up doing a lot of that surgery, which is what happened with me on like lip surgery, like certain types of lip surgeries, I like started to write articles about it, like, put out these videos, go to conference. I still go to conference every fall. I go to Miami for a conference where I go and I lecture at other surgeons on the things that I do a lot of so that they can improve their skills in things that, like they might do once in a while. Right. So the people who are doing that thing all the time, they start to see like little nuances, little pearls that you gather, and ideally, you train the whole community in that. So, but you have to like develop that on your own, and you're from each patient, you're picking something up like, oh, like I did this, I used this suture, and then you have to use it a bunch of times, and then you're like, okay, I like how people heal more with the use of this suture than that suture, so I'm going to switch. Or I
Mm-hmm.
like how this instrument, because like when you're training, you basically just get handed instruments. You know what I mean? Like you're not like buying your own instrument. Like it's just like whatever the hospital or the clinic has, they just hand you, okay, here's your needle driver. You're like, okay. But then when you're on your own, especially in a private practice, you start to realize, wait a second, like there's lots of different versions of needle drivers, and which one feels best in my hands, and you try them out, and sometimes it's not a great flow to the surgery, and whether or not that impacts surgical results, you hope not, but listen, you kind of are, it's like a kitchen. It's like you're kind of like figuring stuff out, putting ingredients together until you reach a point where you're like, okay, I'm getting very consistent results doing it in this specific way. Um, and I think based on my experience, it takes at least a few hundred surgeries in a specific surgical subtype to get to that point where you're like, okay, like I'm not changing anything about my technique. Like, yes, you have to adapt to each person's anatomy, to each person's like wishes. Sure, there's customization, no doubt. But the actual like general steps of the surgery and the actual instruments that you're using and like the way you're throwing your stitch or whatever,
Mm-hmm.
there comes a point where you're like, all right, like this is sort of as good as it gets in my hands, and I don't
Mm-hmm.
have a need for any further changes because the results are coming. I mean, listen, results vary, right? Because people take care of their incisions in different ways. People just have natural healing abilities that vary. People have different anatomies. Sometimes you do the same surgery, remove the same amount of skin, and someone just has maybe more optimal underlying anatomy then makes
Mm-hmm.
their final result just look better. Like if you were to show 100 people, 95% will say this person, they just look better, and it's because they started off looking better. Do you know what I mean? Like there's that. So there's lots of things, but still, like I've reached the point with the surgeries that I'm currently doing where like I'm not really changing anything about the flow of the surgery. It's the same basic steps, the same sutures, the same needles, the same whatever, because it just like works in my hands. I'm not saying it's the best way to do it. I have colleagues who have slightly, but what you also find is that the people who are performing at a very high level and producing consistent results in whatever surgery, not plastic surgery, but like the specific surgery that they're sort of expert in, the techniques end up being very similar, and that's
Mm-hmm.
what's interesting. Everyone kind of finds their own way, but like you start to kind of come to more or less the same basic things. There might be some some little differences, but it's going to be a very similar flow because that's what's producing the best results.
But then, does that mean the skill set that you have in doing cosmetic procedures is very transferable to people who have, for example, congenital defects or who have trauma or who are suffering from cancer, those other repairing situations?
Yeah, I mean, in many ways, yes. Again, if someone had like a facial trauma like today, right? Like, would would they want me to perform their reconstruction or someone who's just as well trained, but is doing trauma repairs day
Mm-hmm.
in and day out? I mean, I would go with the guy who's doing trauma. But if it's someone who, doesn't do trauma often, or is just isn't a great surgeon, which exists, some people are just either they're cavalier, they don't have attention to detail. I mean, there's lots of things that make for not a great surgeon, or they just don't care. Like some people just, they don't really care. They just want to go home, so they're just like get done with the case just to get home earlier. You don't want that person operating on you, even if they're doing the same surgery day in and day out, because they might not be doing it very well. But if it's someone who, cares and is meticulous and has nice results, yeah, you want the guy or the woman who's doing it all the time. I mean, ideally. So right now, yeah, I mean, there's certain things that I was trained to do that I did for a number of years, but that I just don't do on a daily basis. So maybe I'd be a little rusty doing it. But yeah, but there are still certain basic things that I could pick up, today or tomorrow and just do and still do a good job because, I care about the patient. I
Mm-hmm.
care about doing good work. You have to like care about your craft. Not everyone cares about their craft. I mean, you would think maybe that surgeons always care about what they're doing, but that's not necessarily true. I've seen that. I mean, some people just treat it as a job, and ideally you treat it as more than a job. So yeah.
When you're doing revisions, then, or when you're working on a patient who has had previous procedures done, can you tell if their surgeon was good at their job? Is that easy for you to see in the operating room?
Uh, yeah. Nowadays it is for the surgeries that I do, and I'll never say if someone has clearly like terrible work that was done. My approach is never to really poo-poo the other person. I don't know. I just don't do that. Uh,
Mm-hmm.
I might tell the patient that, look, my approach is different. I'll tell you why I do it the way that I do it. Uh, but sometimes, I could tell that the work was pretty good. It was really good. And I'll tell them, I'm always happy when someone else is doing good work because there's not that many of us in general, like that are really doing like top-notch stuff, in whatever area that they're in. There just really aren't that many. And it's almost sad, but it's like because you need to invest yourself in like only a specific thing, and you need to do a lot of that thing, and you have to like care and like innovate and whatever. So when I see great work being done by like a colleague, and I might not even know that person, but then if I see the patient, and it might be different reasons why they came to me and didn't go back to that other person. It might be distance, maybe they moved, maybe they were just looking for a fresh approach. But yeah, I'll be the first to admit, like, I'll be like, this was really well done. Or sometimes it's like hair surgery, for example, that was done 20 years ago, and the
Mm-hmm.
surgeon retired, and now they need someone else to do the next one. And I'll be like, yeah, this is great. I really love how natural things look, and we're just going to build up the density, or we're going to work in like a different area than where they worked originally. But I get honestly excited about it because I'm like, this is quality stuff. Like I just like quality. Like I like quality in most of like things I do in life, and I appreciate quality things. So when there's quality surgery being done, especially aesthetic, which is hard. I mean, in general, surgery is hard, but it's hard to aesthetically, change someone in a way that they look better but still very natural.
Mm-hmm.
That's not easy to achieve.
Then let's talk about some of the technical aspects. And I suppose it would be smart to start off with hair restoration. So To start with, how do you assess the underlying cause of hair loss? Because there's hormonal changes, disease, genetics, and so on. So, if I was to come into your office and with some a receding hairline or something, how would you first assess what was causing it?
Yeah, so hair loss, it comes down to patterns, very more often than anything else. So of course, like anything in medicine, taking a good history, finding out when the hair loss started, if it's following like the natural, you know, course, is important. Um, Finding out family history, is there
Mm-hmm.
hair loss in the family, mom's side, dad's side? How do people look, Um, I always like to know how active the hair loss is because that actually goes more towards candidacy for surgery. Because if someone's actively losing hair, I'm not going to offer them surgery right away. We want stable foundation always, and
Mm-hmm.
gets into the whole other thing about medical therapy and whatever. But I'm not going to go off on a tangent on that yet. But yeah, so you get a sense through the history, through just the way that it physically looks, like doing this long enough, you start to see patterns. And people sometimes ask me, oh, what Norwood scale am I don't know if you've heard of Norwood scale, whatever. It's just like the scale in hair loss. But it's like 7 levels, and like 7 is like you're like fully bald, and you have just a horseshoe, and 1 is like there's almost like no loss, and 2 is like a little bit of corner recession. But the truth is that there's so many variants of the scale that most people don't fit into, 1 through 7. And so when people actually have a consult with me, I'm always like, who cares? I'm like, who cares? And then they're always surprised because they're like, what? Like they think I'm going to be like super technical. But hair loss and hair restoration is a lot of gestalt, like you just get a sense, you get a sense of the pattern, you get a sense through the story of what the history, but also the current stuff of what's going on. So there's a lot of that. And then there's like, of course, versions of it that sometimes the patterns don't make sense. And that might make me want to, dig deeper, see them in person before offering them surgery, do a biopsy of the scalp, run some blood work, especially for women, because there's a lot of hormonal stuff that can lead to kind of diffuse thinning. But all of that while realizing that most hair loss is androgenic alopecia.
Mm-hmm.
That's just like how the numbers play out. So it's fair to, I mean, you always want to look for the zebras and the, but especially a condition like mine, you don't want to be
Mm-hmm.
operating on someone who has, especially as severe of a form of alopecia areata as I do. There's a different type of treatment for my condition. That I actually refer out to usually dermatologists who have like certain medications that they can prescribe. But yeah, so that's how I sort of assess, that those are all the things that I take into consideration. And so, yeah, I'm very cautious before I like, especially I offer surgery, because the last thing you want is to pick the wrong candidate. They have like, say, a scarring alopecia, you did the surgery, nothing grows. you know there's always some theoretical chance of that, but usually if you're careful, you can select those patients and say, whoa, based on what I'm seeing, this doesn't look standard. We should do a biopsy. There might be some underlying inflammation in your scalp, for example. So yeah, and if they don't want to do that, then they don't get surgery from me. They just go somewhere else, I guess, and get their procedure done.
Mm-hmm.
So I will put up those kind of barriers. And also on the medical history side, like meaning if they've had prior, heart surgery, if they're on certain blood thinners, I get all that history myself. To this day, I definitely could. I have plenty of team members now. I can easily get someone to get that history for me to save time, but I choose not to because I feel like if something gets lost and my nurse forgets to ask, or she didn't hear that the person said they had something underlying, not with their hair, but like with their general health, and then we miss that, and then we don't run the proper testing before, and then God forbid, something goes wrong during the surgery because of some underlying condition, I mean, I just wouldn't be able to kind of forgive myself for that. So I still get, and it doesn't take long. Most of my patients are very healthy. I mean, sometimes people
Mm-hmm.
have conditions, and we sometimes have to get medical clearance before even offering them surgery. But yeah, so I'm even cautious on that front too, because I want people optimized for surgery. And then the forms we send them, that give them all these things about, they should stop certain vitamins and supplements and, avoid coffee for X number of days before. So, that lots of things to, again, just make sure that the surgical day goes as smoothly as possible.
Could you walk me through the key technical steps? So, what are the key steps involved for someone who is actually getting the surgery done?
Yeah, so for a hair transplant, there's three basic like steps, right? There's the part where you have to create the sites, like the homes of where the grafts will live. Like, so you have to create the, it's like gardening, you got to create the whatever, dig it out. And then you have to get the grafts. So you have to like have your donor area identified. Usually it's the back of the head, but sometimes we're taking from the neck or the chest. Like we get creative with that, but usually it's the back of the head. So you have to harvest the grafts, right? And classically, there was like the strip technique where you cut out like a segment of the scalp and then break it up into the little grafts under the microscope outside of the body. And then around like 2010, FUE, which is the one by one extraction, became more popular. Excuse me. So that's like mostly what we're doing, especially for men. For women, we still 50-50 or maybe 40% of the time we'll do an FUT strip procedure to get the grafts. But that's step two is get the grafts. And step three is to place the grafts into the homes or the holes or the slits, whatever you want to call them, that were created. That's it. I mean, it's a three-step process. That's the basic steps. I mean, there's a lot of, nitty-gritty things, but yeah, but that's what it is. You need a source, you need like a destination, and you need to create like a home for the grafts.
And how precise do you need to be when you're placing the hairs into the recipient sites?
Well, so the two basic ways to like create the sites, one is with like a blade or a needle, where that's the way I do it. So it's like pre-made sites where you're making the sites first, and then later on when you have the grafts, the team will put the grafts into the sites, right? And the site will dictate if it's done well and properly. It'll dictate the angulation, the direction, the density, all that's it's like the blueprint for the result is how the sites are made. So I always do that 100% of the time because that's the result. Um, of course, it matters how your team handles graphs and all that stuff. But the other way to do it is to use what's called an implanter pen. And that's like this little pen like thing that has like a release button on it. And so you feed the graft into it, and it could be sharp or blunt actually. But let's say it's sharp. So you put it into the skin, to the scalp, and you just release, and there's like a twisting motion, and it leaves the graft in place. So you don't have to then pre-make the site for the graft. It's essentially like a single motion. That's kind of those are the ways to do it, and so some people I just learned more on the side of pre-made sites, so that's what I feel comfortable doing. Other people learn more about like the implanter pens. There's pros and cons of each, but I like the flexibility that the pre-made sites give me, because once you start using the pen, there's the risk of popping. Anytime you start placing grafts, you can get popping, and that's like you put one in, and then the neighbor starts to come out. So now you've got to readjust and get the neighbor back in and then come back in and put your, so it just kind of slows things down, in my opinion. So we're more efficient making sites early on in the day, and I always do that. Then we harvest the grafts, and then the afternoon is placing one by one.
So, how many hours does this take?
Long time, yeah. So we're doing bigger surgeries for hair than we used to, right? When I started, it's like, smaller procedure can take all day. So it's like, I was doing maybe up to, I don't know, 1,400 grafts, 1,500 grafts, something like that. 1,800 felt like a forever day, like it was never going to end. Nowadays, we're doing cases of like 2,500, 2,600, sometimes even a little bit more. And yeah, I mean, it's still a long day. Like it could take us like 10 hours, sometimes even a little bit more, because there's like actual working time, and then there's like just time that people are in the office, because it takes us time to set everything up, to figure out a plan. I'm super like I mean, we released a video a few weeks ago on like it's called How to Fix a Receding Hairline. and it's actually like my thought process for designing hairlines. So uh, I'm very anal about that process. So a lot of people just draw a line. They just come in with a Sharpie and just draw a line, a thick line, and it's just like that's what we're doing. You could do that. I mean, you can eyeball it and just draw a line, and that's fine. But we measure, and I use little tiny dots instead of lines because I mean, when you have a line this thick, are you putting the graphs on the top of the line, the bottom of the line, the middle? Where are you putting the graphs? So I use like little tiny dots, and everything is kind of measured, and like, it's just there's an artistic side. And that's, I
Mhm.
think, something that people don't realize. They're focused on how much is it per graph? Am I going to Turkey? Am I staying? It doesn't matter. It's just like you pick your surgeon and someone who has like an artistic view on things, and doesn't, if it's cheaper, great. If it's Turkey, if it's Mexico, it doesn't matter. It's just like I always tell people, like, you gotta pick the surgeon. Don't focus on this place is a little cheaper than that place. Like, that's not, the people are, and then they also, people will hyper fixate on like which tool is being used. It's like, are you using the artist robot? Are you using, the latest implanter pen? Like, what tool are you? And I honestly, uh, I used to be more like, let me tell you what we're using, and I mean, I still do. I don't want to be rude, but I'm like, and sometimes I just come out and say it. I'm like, it shouldn't matter to you what I use. And that's truly how I feel, because like if you go for a haircut, right? Like, are you picking, assuming, like it's someone who, like, not just like you randomly are like, oh, I just need a haircut, but if you're like, your regular person, like you're picking the person, right? Who's going to cut you. Like, are you ever asking them, like, what scissor are they using? Or like, what's the spray? I mean, it's just like they use what they use, like, but you like what they create, right? And so you go back to that person. So it's really like that with surgery, but I think people they get lost. They don't know the questions to ask. They don't know what to look for. So they're asking about the robot. They're asking about, whatever. I don't know who's doing the surgery. I mean, there's certain questions that are fine to ask, but it's just like look at the before and after gallery and get a sense. Is this like artistic work? Is this honest representation of results? And can you find something else out about the person online? Do they have reviews? Do they have some video clips on their, something to give you a sense of comfort? And then call the office, schedule an appointment. It's shocking how many hair clinics have like it's the uh it's the sales rep who's doing the consultation often, which is insane. But that's how it is. I mean, in most other cosmetic surgery clinics, that's just not really the case. Like if you're getting a breast augmentation and you schedule a consultation, you're going to meet with the surgeon. But for whatever reason, in the hair world, and I think maybe because of the Bosleys of the world, where it's like, the franchise mentality, right? If we want to improve our bottom line and overall kind of business efficiency, yeah, stick the sales rep in there, have them talk to the patient, keep your doctor for other things, whatever. But like, it's not fair for patients because like they're trying to get a surgery, they're not trying to get a haircut here. Um, so so that's, yeah. So make sure that like for patients that they're talking to an actual surgeon in consultation, and not like you'll talk to the salesperson and they show up day of and then maybe they'll shake hands with the surgeon. I mean, that's not right.
Before we have to wrap up, I want to ask you about facial procedures a little bit. When it comes to rhinoplasty, so nose jobs,
Yeah.
what can you actually achieve? So in terms of shape, size, uh, realignments, what can you achieve, and what's out of the realms of possibility for rhinoplasty?
It's always easier to take away than to add in, right? So with filler, for example, people get these liquid rhinoplasties and they're just adding material, right? And so a lot of times it's not giving people the look that they actually want, which is usually to take away. Sometimes people have like very flat hump, like the dorsum, we call it, is super flat or scooped, and those individuals might want it to look a little bit more streamlined and a little bit more projected. So then you have to add, and that's actually a hard thing. I mean, assuming you're not getting filler, um, to surgically augment and to add, or let's say if someone has had a prior rhinoplasty where they took away too much cartilage, right? And now everything's kind of like caving in, and they can't breathe, and they're miserable, and you're looking to build that up. Hard, very hard. I mean, you need to get cartilage from somewhere. So if the cartilage in the nose was previously exhausted, now you got to go to get ear cartilage. Now you got to go to get rib cartilage, either from the person or from a cadaver, or you're using like artificial materials like silicone, which isn't great at all, but sometimes it gets used. And so building and getting building materials like a house, I mean, it's hard work, to knock it down and to take away. I mean, to knock things down well is hard, right? Because obviously most of the time we're still taking away. But like, let's say someone has like a hump like me and you're trying to like smooth it out. There's a series of steps to make that look natural and to not overdo it. Again, therapeutic window. You can scoop out the nose and drop the whole thing and make it look terrible. You can also do so little that I'm left with the same exact hump that I had. So you're trying to bring it down, but safely and securely and in a way that it won't shift over time. So there's an art and there's a science and there's just the feel of it, and you try to achieve your patient's goals, because some surgeons, they go in and they don't really care what the patient wants. They're like, I'm going to give you the nose you need. That's the mentality. Sometimes it's a little bit more old school, but and the patient comes out of it and yeah, maybe their nose doesn't look too bad, but like that's not what they wanted. So there's no like time to like, let's figure out what you want. Like what, like to me, that's kind of obvious, right? Like you want to hear the goals, but it's amazing how many surgeons, they don't really listen to the goals. They're like, I know what you need. You know, we need to get the hump down. We need to bring the tip in. What if they didn't want the hump down? What if they just want a little bit of tip work? What if they just want a little rotation of the nose up? So trying to figure out what the person wants is so critical, right? And then being able to execute, and then hoping that, because the results take like a year, hoping that nothing gets disrupted, that they don't bump their nose accidentally, that you don't get excess scar tissue that grows that makes your results look worse than they are, but it's like not necessarily your fault. Or if the person has really thick skin, the swelling is going to linger for longer. And so, everyone always says 1 year. The nose doesn't read the textbook. Just because we tell patients it might take a year for you to see your final result, sometimes it takes a year and a half. Sometimes it takes 2 years. And the thicker the skin, the longer it retains the edema. So it's gonna look bigger for longer. So it's gonna take you longer to figure out, what's the final result of the surgery that happened maybe 2 years ago.
So one thing I want to understand better is when you're reducing the size of someone's nose, how do you do that without having excess skin and scars?
Well, I'll tackle the scar question first. So for scarring, there's two approaches to a rhinoplasty. You can do an open approach where you make a cut right here, and that usually heals extremely well, usually much better than my lip lift scars. So because I used to do both at the same time. So because the skin is thin and there's not much tension on it, so it heals really well right under here. But there's also ways some surgeons choose a closed rhinoplasty approach, and that's all cuts made internally on the inside. And you can access the entire nose just through cuts like that. But there's no reason for additional cuts, unless you're doing some complex cancer reconstruction. So yeah, those are the common so even if you have an open approach and you get this little scar, almost on everyone it heals so well over time. It's just like not, it's almost like a moot point if you have an open scar there. It doesn't really matter. It looks great. Excess skin. So yeah, when you drop the nose down or like you deep project the nose, there are times when you get a little bit of extra skin, and you can, especially if you have an open approach, you can resolve that excess through, before you close, you just remove a little bit of skin. But there's usually not, I mean, these changes are not so dramatic, like for a facelift, for example, where someone's like super saggy, let's say, and you can remove like this much skin, Um, but for rhinoplasty, you don't usually have a ton of excess.
Okay. One of the common procedures that people have done is fillers, lip fillers and so on, cheek fillers. I don't understand how the cavities under the skin actually work. Do you have one large cavity, or do you inject into multiple places? And if you do inject into multiple places, how can you reverse the procedure if someone doesn't like that? If you've got, if you imagine thousands of locations.
Yeah, great questions. So there are, different layers to our tissues. And when you're injecting filler, it's all about what you're trying to, achieve with that filler. So if you're in the lip, for example, first of all, there's no real bone here. I mean, unless you're going right onto the maxilla or the mandible, which wouldn't make much sense to plump up the lips by injecting onto the bone. You know what I mean? So if you're plumping up the lips, your injections are generally into the lip itself, right? So that's like a soft tissue injection. If you're working on the cheekbones, your injections tend to be deeper onto the actual bone. Partly it's because of where blood vessels are, and you're trying to stay safe and avoid some of the major blood vessels. And sometimes being on bone is actually a bit safer than not. But it's also like what you're trying to achieve. So, for example, for the medial cheek, usually you're going to come off of the bone. For the lateral cheek, you're going to stay on bone. So there's like different sort of nuances with that. And then what was the second part of the? Oh, if you're not happy with it, yeah, but keep in mind, look, filler can migrate, and it doesn't, it can be clumpy sometimes. It can migrate. It's not perfect. And yeah, so when you go to dissolve, if you've injected an HA, like hyaluronic acid filler, you can use hyaluronidase to break it down. But if it's now in multiple planes because your injection has been like through multiple planes, you can imagine it's hard to dissolve all of it. So you might get a partial dissolving, but you might not get it all. And especially if it's been many years and now it's like kind of migrating a little bit. So people are realizing now filler lasts a lot longer than was previously thought, even the temporary filler.
So I realize we have to wrap up. Let me ask you one just fun question before ending off. So I'm not sure whether this would ever happen, but let's imagine that someone came into your procedure and they just wanted to look different, unrecognizable. So they're on a witness protection or whatever, make up whatever scenario you want. Say it was me. What steps would you go through to augment this person so that no one would ever recognize them, but they would still look natural?
I mean, I wouldn't offer that type of surgery myself. Like I wouldn't take them on.
This is an
But
imaginary scenario.
yeah, to imagine, yeah. So implants can change someone's face quite a bit, and there aren't that many places that are routinely doing facial implants, but like they can be powerful in changing someone's look. So both ways. So basically, like you have to do something that's a little bit more bony. So either you're using implant to augment their natural bony structure, or it's the other way around, where you may have heard of like V-line surgery, for example. It's
No.
thought of as being a bit more feminizing, but I mean, I guess that's one way to change them. Uh, but like for trans people who are transitioning, they go and they get these surgeries sometimes where if it's like a male to female transition, and they're reducing the contour of the mandible by like having it shaved down. The chin gets a little bit less wide. Here you can kind of shave it down. So making those types of adjustments can really change someone's appearance quite a bit. You can also do that to the brows, like the brow
Mm.
bones. You can kind of shave them down. Or you can put an implant to go the other way around to make the brow ridge look more masculine. So I would say, especially like if you're looking at procedures that cause someone to look more masculine or look more feminine, that can surely change someone. But if they're just trying to stay within the gender and look different, I mean, you just take whatever features they have and you kind of like you have to tweak them, either augment them or reduce them. But certain things, when you do that, will make someone look either more masculine or feminine.
What are you most excited about in the future of plastic surgery?
I mean, we released a video about like AI and how it might change how we look at like basically the utility of plastic surgery, for better or worse. Like, will it make plastic surgery obsolete in 5 years, or will it actually make it more popular? And we saw it from both perspectives. I thought the video should have done better than how it did, but that's the YouTube algorithm. Uh, but I don't know if I see like plastic surgery changing like that much over time. I think the biggest change over the years has been people's willingness to talk about it. So
Mm.
that's probably one of the biggest changes in, I mean, since the birth of at least cosmetic plastic surgery. Like people are getting cosmetic plastic surgeries in like the 60s, 70s, maybe even 50s. It just wasn't talked about. It wasn't commonplace. The procedures weren't maybe as effective. It was only available to like, because think about it from the doctor's perspective. It wasn't like there was a whole network of cosmetic surgeons. Uh, so it was a little bit more, under the rug, like kind of like secretive. And then, it started to hit Hollywood and still super secretive 80s, 90s. I mean, it's only like what, over the last 5 years that somehow, for whatever reason, new generation, social media, COVID, I don't know, but people have just been more open about it. And so I'm optimistic about that, but at the same time, I think we need more people like me wanting to talk about not just like pushing surgery onto people and being like, oh, well, I make money this way, so get more surgery, but like kind of really diving deep into like teaching people about the nitty gritty specifics of the surgeries, like the steps, like the general steps, and what it's about and how they can make informed decisions, and also raising like risks of certain procedures, both surgical and non-surgical, in again in whatever specific area that they deal with. Like I couldn't have a conversation like that about breast surgery in the type of detail that I can about a lot of facial stuff. So why not have a breast surgeon speak to all this stuff? But what I see on like Instagram, for example, is much more, yeah, there's some education, but the driving force seems to be a lot more on the marketing front. And these short videos sometimes don't do these topics justice. So I'd like to see more people creating long form content to educate about plastic surgery. So I think that will come, but it's hard work. I mean, it's a lot of work because look, these are surgeons who have busy lives, in and inside and outside of their actual jobs. And now, they're being asked to like make long videos. Like that's it's not always fun for everyone. So I find it fun because I like to educate, and it's just like a good thing I think to do, but not everyone sees it that way. So, but with short form, I see some colleagues taking really interesting, clever approaches to still educate and teach, and to really like show people like recovery, like being more honest about like, look, people look like crap, a few days after surgery. Like they don't look good, it takes time. So I see some colleagues like showing people over time, not just like the before and after, where the after is like, 3 months later, a year later. So that's good, that's great. So we need just more of that honest education.
When you're 80 years old and you're retired and you're looking back at your career, what's going to make you happy and what are you going to be most proud of?
Yeah, that's interesting. I think when I'm 80, yeah, that's a long time away, but yeah, it'll probably creep up on me. Yeah, I mean, I think reaching, and that's what I've realized, YouTube versus just like my practice. Like I can only do like a couple hundred, maybe up to, I don't know, 400 surgeries a year, with the type of stuff that I'm doing now, because hair takes all day, and that's a good impact, but that's limited, right? So if I can use the online platform to reach, millions of people, which is where it's heading. I mean, we already have over 100 million views, like total views on the channel. And if we continue at that rate, and I I also want to get into podcasting and bring interesting people on in the beauty sort of aesthetic space. And if we're just like creating a more transparent, like honest community that helps people feel good about themselves, and like really doing that on like a large scale, like internationally, because I have ideas for like an app, like a beauty app, like all these ideas. So if I can do that and just reach like a ton of people, but then like have like a very positive spin on it, and not just like, doctors making money and patients getting stuff done, but like, having a richer experience for everyone so they can make like the best decisions possible. I mean, that will feel great. And I think there's a need for that. It's not like it's being done and, I'm just like another guy. Like I really do feel like we're pushing the envelope, and we're just kind of starting to push the envelope, because I have like bigger ideas for how do we get this out to, like, again, not beyond the United States, like just internationally, like, so that, because I want to find good like matchings between providers and patients. And I expect that the providers, need to be at their optimal. You know what I mean? Like they need to, if they don't know enough, then fine, learn, figure it out, learn, train under somebody, but don't start doing stuff willy-nilly. Like, really offer people the best quality stuff. And then I want patients to then find their way and stay safe, throughout all of it. Because I think there's a lot of good that can come out of plastic surgery, cosmetic plastic surgery. And I see that. I see it in my practice. I see it with my colleagues. I mean, people are generally very, very happy if the right thing gets addressed in the right way. But there's a lot of potential problems and a lot of people who take advantage because it's more cash based. It's not like insurance usually. And people take advantage, they want to do the least amount to make the most amount of money. And that's not good. That's not good. And then people can get hurt. And then it honestly ruins it for like sort of the rest of us. Cause like, right, if there's like a botch result that gets spread around the web, like, oh my God, look what cosmetic, or someone dies from a cosmetic surgery. It's like, oh my God, they're killing people for no reason. They don't even need to get these surgeries. And it's like that there's a reason why that happened. It's almost never, I mean, there's always like freak things that can happen in the best of hands, but it doesn't really happen. I mean, that kind of stuff happens in places that are not as like monitored, not as safe. People are doing things they shouldn't be doing. So yeah, so just having like the best overall community that almost self-polices and not depending on like the government to come in and like police us to like be safer and do better, that would be great.
Gary Linkov, it's been a pleasure.
Thanks, Shane. Yeah, this is great. I love
Thanks
talking
for
about
coming
this
on.
stuff. So thank you for having me. Appreciate it.